Not like Instagram, that. Normally it's Facebook. I need a haircut, don't I? I mean, let's not beat about the bush. Oh, I need an urgent haircut. Anyway, look at my followers. My followers honestly, my followers on Instagram will be absolutely distraught. Anyway, let's crack on Facebook. We started. I don't even know what to do. What do I do to make it better? I don't know what I can do, to be honest with myself. Don't know putting those things on. Anyway, right. Okay, let's push on. Professional to the end. Hold on, we're telling. So something's definitely happening on Instagram. But anyway, never mind. Crack on. What's all these? Oh, mute. Ooh. Okay. Go live in a room. What's that? Anyway. Oh, is it working? Oh, it's working now. Let's come back on. Come back on. Right. So what we got here is a question which says, do you offer to remove birthmarks such as cafe au lait? So cafe au lait patches are slightly pigmented. They're not usually very darkly pigmented, but they're slightly pigmented, slightly brown patches. They're flat patches that people have on their bodies, and I guess that would qualify as a birthmark. So the answer to the question is plastic surgeons can remove anything. You know, a lot of people say, oh, tattoos, do you do tattoos? Do you do, you know, any bit of skin in any part of the body, pretty not even pretty much. I think any bit of skin in any part of the body we can remove. The problem with removing bits of skin, whether it be a birthmark or a mole or a tattoo, is it leaves you with a scar, and therefore it is not common for us to remove cafe au lait patches. So I would not commonly remove a cafe au lait patch because what I do involves excision, cutting things out, which will leave a scar. And so it would depend on the size and location of the cafe au lait patches. They can be quite large, not necessarily though, but they're usually not that much of a cosmetic burden, if you like, or they don't usually look that bad. And so if I go ahead and then put a big scar where the patch was, you may not be happy. You may be. We can have a chat about it. So I'm not saying I won't do it. I'm just saying it's not a common thing. Can't remember the last time I ever did one. You know, it's just a very lightly pigmented area of skin, and so I probably wouldn't go down the excision route personally. But then at the end of the day, I'll be guided by you. It's not my body, your body. We can have a chat about it. Let's rap about it. Elaine Grant Hartland, can't wait to see you in 6 days. Not that I'm counting or anything. 6 days, I'm counting too. Elaine Grant, it is 6 days time till takeoff, till lift off to the big day. Very, very exciting. What we got here, after having liposuction to the hips and thighs, what happens to the excess skin in those areas? Does it sag or does it tighten? This is a patient who's got localized areas of fat on the hips and on the outer thighs, the so-called terrible name of saddlebags, but it is not unusual to have that sort of distribution of fat. And this person is a great candidate for liposuction. She's not overweight. Liposuction is not a procedure for people who are overweight. It is a procedure for people who've lost weight, who are comfortable with their weight, who have certain areas which are resistant to weight loss. And there are certain parts of the body that liposuction works well on. And the outer thighs and the hips are two of them. The inner thighs, not so much. The abdomen, not so much. So a lot of people come in wanting liposuction of the tummy. I pretty much don't do it because the problem with the tummy and the inner thigh is the skin doesn't recoil. And if the skin doesn't recoil and you suck out the fat and you have hanging skin, you can have an unhappy patient. So those areas, excisional procedures are better, tummy tuck or a thigh lift. Now, a thigh lift addresses the inner thigh. The outer thigh has got thicker skin, thicker dermis, and it tends to recoil a lot better. So the skin, in answer to your question, what happens to the excess skin in those areas? It tends to recoil. Now, it might not, and certainly someone who's carrying a lot of weight, who's having a lot of the fat removed, it might not recoil sufficiently, but it would, in my view, be better to consider possibly doing an excisional procedure secondarily, unless there's obviously going to be a lot of loose skin left behind. To be honest with you, I follow the same sort of process with gynecomastia. So my threshold has moved on from doing skin excision in gynecomastia. So I tend to do gynecomastia with liposuction and excision, a combination of those two things. And I tend not to excise skin unless there's an awful lot of skin and I really think it's not going to recoil. I feel it's better to see how it recoils, and it might recoil sufficiently. And if it doesn't recoil sufficiently, you might be able to do a more limited skin resection than you would have done if you'd done it first time. Not 100% true all the time, and some people are you do think, look, you're going to need a skin excision because it's really not going to be good at all if you don't do it. So obviously there's sort of extremes, if you like. There's people who are definitely need a skin excision and there's people who definitely don't. But in the grey area, I'd be more inclined to avoid skin excision in gynecomastia and also in the outer thigh. So I would tend not to, bringing it back to this question, the hips and the outer thighs, I tend not to do excisional skin. I don't tend to cut skin out. Liposuction works well, and the skin tends to recoil. Depends on how much skin there is, depends on how much it's been stretched, depends on the quality of the skin. Have you been looking after your skin? Have you been not smoking, staying out of the sun, drinking plenty? All these things improve your skin elasticity, not getting old. So, getting old, smoking and getting in the sun will all cause us to lose our skin elasticity. So there's less recoil. So obviously it depends on different people, but as a general principle, that's where I am with that one. Corinne, what you got? Hope you had a good day. I have had a good day, Corinne. I was looking forward to today because I don't normally do a clinic on a Tuesday, but I did a clinic today, just saw a couple of patients, and quite nice, Only problem is I've got to do another one tomorrow, but hey ho, can't have everything. But it was a nice day today. I did plan to get off earlier than I did though, Corinne, and I did go to TK Maxx on the way home, and I wanted to buy something specifically, and I couldn't find it. I wanted to buy some little cards. I couldn't find them. Not thank you cards, just little cards. So that was a bit of a blow. And my son's train was cancelled as well, but my wife picked him up. So, a bit ropey at the end of the day, but certainly the big part of the day. And I had a call at 3, which was cancelled as well, which was a bit frustrating because it was some software in America that I was supposed to be having a look at, but that was a bit of a frustration. But you can't have everything. But yes, Corinne, I don't think you probably didn't want that amount of detail, but hey ho, probably overshared there. Do we remove cysts located in the hair? Yeah, duh. I mean, one of the things about the hair is that when you start in A&E and things, they always make you do the scalp lacerations. They always make you do people who've got these cuts in the hair. And the reason they do that is because it doesn't matter if you don't lining it up very well. It doesn't matter if you don't get a very good scar because it's hidden in the hair and it doesn't matter. Sounds awful. Whereas the facial lacerations, they call in plastic surgeons, say we mustn't do those. We must get the plastic surgeons to do the facial lacerations. Now I'm at the other end of it. I'd much rather do a facial laceration than a scalp laceration. Scalp lacerations are a bit of a nightmare, or even scalp incisions, a bit of a nightmare. There's hair all over the place. Personally, I don't particularly like shaving big areas of the head. So I don't like shaving the head. Obviously, it'd be a lot easier if we just shaved the head and could get some nice stitches in and the hair wouldn't get caught in it. But I don't like shaving the head. So I tend not to shave the head. But it does make it a real bit awkward when you're stitching it up because the hairs can get caught and you have to keep on getting the hairs out. So, but it's absolutely fine to remove cysts locating in the hair and moles located in the hair and anything. You can cut things out in the hair. And as I say, personally, I try and avoid shaving the hair myself. I try and leave. I might take out the hair that's in the bit of skin that I'm removing, obviously, obs. But yeah, cysts in the hair, walk in the park. Corin, what you got? I can never find anything to give back. Says, oh, Corin, I'm the opposite. See, I don't like having the choice of anything. TK Maxx have got like 1 or 2 things. You think, do you like it? Yes. If you don't know, move on. You know. I'm the opposite, Corin. I love to browse in TK Maxx. I said it live on air. I do love a bit of TK Maxx and HomeSense, mind you. What we got here? Can I have a mole removed whilst pregnant? This is a good question. The answer to this question is basically we try and avoid doing stuff when you're pregnant. We try and avoid giving you, even sort of painkillers, and just try and avoid taking stuff into your body when you're pregnant. So if it's something like a cosmetic thing that you don't like the mole, it's catching, it's annoying you, I would probably say wait until you've delivered your child and have it later, just because while the baby's forming and everything, you don't really want to be putting. I mean, local anesthetic, I'm sure, is fine, and if you have to have an operation, if you fracture your skull and have a bleed or something, if you have to have a surgery, you can have surgery, but it's better not to have stuff done. The thing is, if you're worried about the mole, then yes, you should get it checked out. And if there is a worry that maybe it's a melanoma or something, then yes, I think it'd be worth removing it. Now, one thing I would say, moles do tend to go darker during pregnancy, so that's something to be aware of. They do tend to darken during pregnancy, but having said that, if you are worried about it, then definitely get it checked out. And if it is any concern, yes, we can remove it while you are pregnant. There's a few things you have to, obviously the local anesthetic, have to be careful lying on your back, especially if you're sort of later on with a big gravid uterus. But there's a few things we have to be aware of. But we can do it. Can be done, but only if it has to be done. Really, if it can wait, it's probably better to wait. We've got lax on the scalp is a nightmare. They are a nightmare, absolute nightmare. They always give it to the junior person, and at the time you think, God, this is really hard. God help me if I had to do a face laceration, but you don't realise the face is a hell of a lot easier than the scalp. Yeah, the hair's in the way all over. I have to put sort of like KY jelly or something to try and get the hair out of the way and everything. But yeah, it is difficult doing stuff on the scalp, but can be done, no problem at all. This question here says, how many steroid injections are required following an intralesional excision of keloid scar? So yes, this is a patient who's asking this question. So in fact, a prospective patient. I don't think they are a patient at the moment, but thinking of being a patient. So think about keloid scars. Keloid scars are lumpy scars, and to be honest with you, we would only think of doing surgery at a late stage. It's really one of the last things you do for a keloid scar. They are caused by your body's reaction to the scarring. Your body has scarred too much, and so if we cut it out and stitch it up, what's to stop your body doing the same thing again? What's to stop your body forming another keloid scar, and potentially bigger than the first keloid scar? Because you can maybe get sometimes a little piercing or a little tiny little injury that you can then get this keloid scar, which is much bigger than the piercing or whatever the injury was, and so that's one of the hallmarks of the keloid scar. It's bigger than the original trauma. So if you have a piercing and get a big keloid scar, if we then cut out that big keloid scar and give you a scar like that, then potentially that could then exponentially get bigger again, and then we're in a right old fix. So what we do is something called an intralesional excision, which means cutting within the keloid. We don't cut normal skin, so we don't cut the scar out and then stitch it up, give you a fresh scar and fresh skin. All the stitches are within keloid. So it's called an intralesional excision. So lesion is the keloid. A lesion just means a thing, a lump or something. So it's an intralesional excision. So that means we leave behind a rim of keloid. So we're stitching in the keloid. And so therefore, if you want to get rid of that keloid, then you can then do steroid injections. You've converted a very big keloid into a much smaller one, which you can then do steroid injections. Personally, I wait 2 weeks before I start my steroid injections. I know that some people do it straight away, which is fine. I worry about it affecting the healing. I noticed just caught my eye here. Instagram saying, what's he doing? Just here, steroid is spelled wrong. It's OID. And I don't know why intralesional is in capitals. Yeah, personally, I'll wait 2 weeks. But, so the question, if this was on YouTube, they'd say, scroll to 3 minutes 36 to get the answer. He's rambling on. That's what they do, honestly. Anyway, yeah, I am rambling on. So here comes the answer. How many steroid injections? Depends. What a nightmare answer that is. I mean, you don't need any injections. If you're happy with a little rim of keloid, then you can leave it. I normally do a session in terms of steroid injections as a rule. So a smaller keloid that doesn't need intralesional excision that you treat with injections. I normally do a course of 3 and then leave it a few months before doing another course of 3. I don't want to keep on doing steroid injections, usually about 6 weeks apart. But it depends. It depends on how much you're bothered by it. Depends if you're symptomatic. The itch can also often be helped by injections, as well as the raised and the red nature of the scar. So you might have one injection and think it's fine. You can play it by ear and come back if you need to, or you can have more injections. Sometimes it needs to be repeated. Now, I am aware that you need to pay for the injections, so you might think they're not worth it. Fine, don't have them. But often you might need several, 1, 2, 3, but we will be guided by you and how well the injections are working. If you think the injections are working, we'll carry on having them. If you don't think they're working, then don't have any more. So it is a bit like guided by you, really, as rather than just saying this is a number of injections. Louise, hello JJ, hope you're well. Hello Louise, I hope you're well. Nice to see you this evening. Can I ask whether a drop in breast implants 8 months in surgery to 1 centimeter is an issue? Will it get worse? Size was 300 cc, so very sensible choice. So this patient has said that she's had surgery. She's obviously 8 months post-op. I think she's doing running and things, and she's worried about the dropping thing. And I think the scar. I think what's happened is the implants are settled, and the scar has migrated up a bit from what she's describing to me, and she's concerned that the scar has migrated above the inframammary fold. Now, in my hands, and with all of these things, the answer is always talk to your surgeon. So I need to have a banner going around the bottom. Talk to your surgeon. Talk to your surgeon. So talk to your surgeon about this. But anyway, I'll put my oar in. The scar often migrates above the fold. So the scar is not always right bang in the fold. You don't want the scar below the fold because then you can see it from the front. So sometimes it migrates up above the fold, which can help because it doesn't sort of go right on where the wire of the bra is. So so that's not necessarily a bad thing. Now, the problem with this thing is that I always say, well, I don't always say it. Well, I don't very often say it, but I always think. Someone said, I can't remember who it was obviously a surgeon when I was in training and things, that we operate in 4 dimensions. The 3 dimensions of, X, Y, Z, how you say it, but then the 4th dimension is time. And this makes this job tricky because implants are often / always a bit high to start with. They're often high to start with, and then they settle. And in this situation, this person is obviously worried the implants are settling too much. And I think she's not stopped running and stuff and is worried they're going to continue to go south and cause an issue. And is sort of saying, when are they going to stop? It's really hard. I mean, I haven't got an answer for that. 8 months is a good amount of time. And again, talk to your surgeon. But personally, I wouldn't not run. I would run. I mean, it's not like running is going to make your implants go south. Certainly 8 months post-op anyway. So I would definitely run. And I would say it's normal for the implants to settle. They often are high and then they settle. Now, the point they settle to is very high. I can't say whether it's going to settle more or not. I don't know. It might settle more. I mean, 8 months, you can be a year, 2, 3 years for these things to really fully settle. I don't think it's going to drastically settle more, but it is very common for the implants to drop, and they often sit high, and they often, the problem is they look a bit weird when you first have it done, and they often start a bit sort of almost abnormally high, and then the hope is they settle into a great place and they look perfect. But obviously, you know, it's not a precise science. They might not settle enough, and they might stay too high, or they might settle too much and they go too low. In my experience, it's usually that they're too high rather than they're too low. And it's certainly easier to correct a problem that they're too high, because you just release the capsule and bring them down. When they're too low, it is a little bit more difficult to correct, because you have to redefine the fold, which is a bit more of a technical challenge. So I would say that they might drop a bit more, even though it's 8 months post-op. I wouldn't let it stop you doing stuff. If you want to do running, if you want to do exercise and things, personally, as I say, talk to your surgeon. I don't know how your healing was. I don't know how, you know, you're going and things, but in general terms, someone 8 months post-op, I would say to them, get exercising, get your, you know, mental health and all this, physical and mental health, you know, all that sort of stuff. And I hope it won't drop more, but I can't say it won't drop more, or I don't know, just see what happens, live a life, roll the dice and take your chances. That doesn't sound good, does it? No, don't do that. Just carry on with your life, and hopefully it'll be all right. Juanita is in the house. Hi, Juanita. Nice to see you here this evening. I've got a question here. I'd be interested to know JJ's view on stopping drinking green tea prior to surgery due to some research suggesting it can impact clotting. So this is I mean, I've seen people who give like massive things to patients to say, this is not, you're not to take this herbal remedy, this, that, this and that, it causes clotting, it stops clotting, it causes wound healing problems, it does this, it does that. And the fact of the matter is, they do stuff. They do, don't they? They do stuff. So I think you're right. I think green tea does cause a reduction in clotting. Now, the problem with this is twofold. Number one fold is I don't have a big list of things that I tell people to stop doing. You know, there are an awful lot of herbal remedies, and you know, I obviously look at the medication you're on, because there's certain medications that can cause clotting, but I don't go so far as to say to look at non sort of herbal things like this. And personally, I also don't tell people not to have non-steroidals, because there are some drugs, non-steroidal anti-inflammatories, ibuprofen, diclofenac, aspirin, Voltarol, those sorts of things can increase bleeding. So, and the reason for that is the yin and the yang. Yeah, it's the yin and the yang. There's good and there's bad. So there's good stuff about bleeding and there's bad stuff about bleeding. Because I've got to be honest with you, the thing that I worry more about is clotting rather than bleeding. So I worry more about DVT PE than I do about bleeding. If you have a DVT or a PE, if you have a blood clot, usually starts in your leg, DVT, deep vein thrombosis, and then can fly off into your lung, PE, pulmonary embolus. So that is a bad thing to happen. That is a terrible thing to happen. And, you know, it is something that would be very frightening. If you have too much bleeding and you have a hematoma, it's bad having a hematoma. You have to go out to theatre. It's horrible. You have another anaesthetic. It keeps you in hospital. It knocks you back on your recovery, but it's not going to kill you. Let's face it. You know, so it is not as bad in my view to have a hematoma. I mean, obviously, you don't want to have a hematoma or a clot, obviously. But the amount of medication, the amount of things that can skew the balance one way or the other, I tend not to go down the route to tell people to stop it. Perhaps I should have done, but I don't. And I think that, as I say, if it does encourage bleeding or stop clotting, then maybe it reduces your risk of DVT and PE. which is a good thing, because let's face it, we give you Clexane post-op, which is a blood thinner. So, we do want the blood to be thin to a certain degree, but we don't want it so thin that you get a hematoma. So it is a balance. It is difficult. And so I don't think the people who are out there telling people to stop green tea or St. John's wort or goodness knows what are wrong. I don't think they're wrong. They just have their view. I have my view. I don't think there's much science as to what we should do on these circumstances. And I can understand why someone might tell people to stop it. But I think it does become, probably the big one actually is hormonal medication, estrogen containing, like HRT, basically, because HRT can cause clotting. So that's actually a bigger deal. And I don't tell people to stop that either, because contraceptive pill, also the contraceptive pill, same, these things can increase clotting, so go the other way. But I don't tell people to stop that because it's a big deal. You have to stop that 6 weeks before. It's a big deal to stop that. You stop the contraceptive pill 6 weeks before, you've got to put into place alternative forms of contraception. And there's potential morbidity there if you have unwanted pregnancies, and there's morbidity associated with that. So nothing is without problems. Stopping things is not without problems, and not stopping things can cause problems. So both can cause problems, and you have to weigh it up. And so I weigh it up and I say, look, I don't tell you to stop the estrogen containing medication, but we do everything we can to increase blood flow and stop clots. So get you up and walking as soon as possible, TED stockings, Photron boots, keep everything circulating, keep you well hydrated. If you're having a big op, give you Clexane. So that's where I am on my fence. So that's the side of the fence I'm on. But you will find people on different sides of the fence, which is why, I always say to people, talk to their surgeons, because other surgeons might have different views on it. But that is my view on it. Thank you for asking, Juanita. Thank you very much. I don't know why I am tired. I can't be honest, I'm a bit tired. I don't know why, because I've got a big clinic tomorrow. As I say, today was just a small one. I've got a big one tomorrow, and I am tired. But anyway, I'm going to have a lie down. It's Bake Off tonight. I hope you realise that. So we're going to have a sit on the sofa and watch a bit of Bake Off. Suggest you likewise. I'm well aware, it's only R7. I'm well aware of that. So that's why I'm still here. I've done all my, I thought I had quite a lot of questions. Did I go too quick? Anyway, whatever. Get over it. You want to come back at me? Come back at me. Yeah, you got anything else? Come on. What you got? Got anything else? No. Anyway, I'm busy. Clearly, I'm a busy man. Very important guy, me. So I can't be hanging around here all night. I am clearly a very busy guy. So, yeah. Okay. So I'm going to go and, have a sit down. I will see you and you next Tuesday or something. Yeah, probably it's half term, isn't it? Will I be here? Probably. I don't know. I ain't making no promises, guys. I know my followers. I know you rely on this, but I am not making any promises about tomorrow night because it is half term. But God knows everyone's ill. They're all having COVID tests left, right, and centre. So whether we've got a full squad next week for half term is anybody's guess. Probably not. We'll probably be staying here. Oh, Donatella. I haven't seen that emoji. Is that a bespoke emoji? Blimey, alrighty. Go watch enjoy Bake Off and get some weather. Do I look? I'm sorry if I tell you what, Corinne, I need a haircut. Never mind that. I need an urgent haircut. Honestly, I get triaged right to the front of the queue of the haircuts. Right, I am going to go and lie down then. I will see you all next week. Have a good evening. Thank you all for participating. And if you've got any questions, what do you do? I don't know, put them in the comments, do you? Or ring us up or email us? Or anyway, just ask it in some format and I'll try and find it and reply to it. Jackie, loving your work. I will see you